Hi, I'm Dr. Bruce Murphy, and I would like to introduce you to the Peripheral Vascular Institute of Arkansas. It's a concept and a reality. Peripheral vascular disease is in virtually every vascular patient, and it's a silent, asymptomatic disease. We used to have a philosophy with asymptomatic vascular disease that we just left it alone until it developed into something that was symptomatic or had signs. But the problem is that peripheral vascular disease, when it begins, it is so silent that it reaches the terminal stages of the disease when finally symptoms begin or you start to see signs. So we have, over the last few years, developed a much more aggressive and more complete approach to peripheral vascular disease, and one in which we get to the disease while we can still do something about it. The Peripheral Vascular Institute of Arkansas is made up of trained specialists who are dealing with the most complex end-of-the-road disease states in this state. The patients that we deal with were previously all sent to vascular surgeons, but almost never do we have to have vascular surgery done these days because we have so many different tools, different approaches that can either remove the plaque or prop it open or laser it or in some way re-establish the vascular tree inside the leg. We're very excited to have put together this array of talent. We have been working for many years in getting this together, and I would welcome you to use our services. We believe that intervening in patients prior to the disease reaching its final stages is better for the patient and is better for society as a whole. So thank you very much.
So peripheral vascular disease relates to buildup of a cholesterol and material in the blood vessels, particularly the legs, the kidneys, the aorta. The symptoms of peripheral vascular disease usually includes cramping and muscle achiness with exertion, which relieves with rest. However, only 10% of people with peripheral vascular disease present with classical symptoms.
Some of the studies that were done show that up to 60-70% or more of patients are actually asymptomatic and have blockages in their legs.
Peripheral vascular disease kind of goes hand by hand with coronary artery disease. Risk factors for it is similar.
If you have blockages in your leg, there's an 80% chance that you're going to have a blockage in your heart. You'll have coronary artery disease.
When I think about peripheral vascular disease and how we define that to our patients, one of the things that became clear to me early on is it's basically the forgotten cardiovascular disease. Most patients are well aware of the risk of heart attack and strokes. Those are very life-changing, huge impact type of events. And we also are pretty aware of the amputation side of things. Patients know someone or have had family members who have had a limb amputation for quote-unquote poor circulation, and for many years there was not much that could be done about it. Poor circulation was thought to be just an eventuality of the aging process, and we know now that that's not the case. I think we're charged with the duty to help them understand that pain is not normal. Functional limitation because you can't walk secondary to pain is not an eventuality of the aging process. It's something that we need to address. We need to evaluate for some hidden causes such as occult peripheral vascular disease.
You want to identify the risk factors. So age,
Diabetes, high blood pressure, high cholesterol,
the smoking, those are some of the risk factors that people you want to screen for having peripheral vascular disease.
Diabetes is most important. People with diabetes tend to have more severe peripheral vascular disease. In fact, they're 17 to 15 times more likely to have peripheral vascular disease than people without diabetes.
In fact, peripheral vascular disease many times leads symptoms of coronary disease by several years. So if it's screened early, you can save lives with heart attack.
But we actively participate in the screening process for all of the patients who come into our clinic if they have existing coronary disease, if they're diabetic, smokers, and have the risk factors for peripheral disease.
When you look at the outcome, what happens on these patients if you don't screen them is quite detrimental. Someone losing a limb completely changes your lifestyle.
And 30% of diagnosed patients actually receive appropriate therapy. Half of the amputations, for instance, at this G-junction don't receive any vascular workup. And we know that 85%, up to 90% of amputations are preventable should those people receive revascularization.
We have a very comprehensive approach to the treatment of patients with both critical limb ischemia and claudication, including ABI measurements, CAT scanning for diagnosis, and then a multitude of techniques for treatment or therapy.
The screening for vascular disease is fairly simple. We use a test called ankle brachial index, or ABI.
It's very easy to do. Simply check a blood pressure in the arm. The highest blood pressure in the arm is compared to the blood pressures at the ankles. Blood pressure in the arm at the brachial part of the arm should be the same as it is in the ankles. That way you have an index or a ratio of 1. Okay? So if your ratio is less than 1, you could have a blockage. And the worse that number is, the higher grade blockage is.
So it's a simple, reliable test, quite reliable, and indeed in multiple studies, in patients who have an abnormal ABI, they have higher chance of dying from cardiovascular disease. So it can be actually indeed one of the screening tests for overall cardiovascular health.
So once we've done the ABIs, then what we do is we've identified whether this patient has peripheral vascular disease or not. So now what we tend to do in our setting is we tend to do a non-invasive workup. Usually that means CAT scan.
Yeah, the CT imaging, basically an IV is started, contrast is given through the veins, that washes through, and the CT scanner follows the arteries all the way down to the feet and images those arteries, then reconstructs those arteries in 3 dimensions so that we can see where the blockages are.
Okay. We average anywhere from 6 to 20 CTs a day. Of those cases, I'd say about half or so are peripheral cases to look at vessels in the legs.
So it's not only an identification of how severe the disease is, but also helps us plan on how can we treat the disease best.
Depending on what that shows us, we might then want to bring the patient to the cath lab and do a direct imaging where we actually put contrast into the vessels and take x-ray pictures. And at that point, we can then decide if an intervention needs to be done or not.
A cornerstone treatment of vascular disease is a lifestyle modification. Exercise is probably the most important, as well as give up smoking. Typical recommendation for exercise for patients with vascular disease is walking up to 30-40 minutes a day, 3 times a week. It helps to increase blood circulation in the feet, and it helps to develop new collaterals, or what we call natural bypasses in the foot. Blood pressure control is very important, as well as treatment of diabetes, as well as treatment of cholesterol, high cholesterol. However, those patients who have refractory symptoms or non-healing ulcers, lesions in their feet, those patients will undergo invasive studies such as direct angiography and percutaneous treatment. There's a variety of devices available to treat people with vascular disease or blockages in the blood vessels.
The one that was developed first was just doing balloon angioplasty. So that way, by that I mean you take a wire past the blockage and you take a balloon and you open up the vessel. And usually you would see that the vessel would be responsive and you would have a good immediate result. What we realized is that balloon angioplasty doesn't have good long-term patency. So what that means is it doesn't stay open very well. So we would see people come back in 3 months, even less than 6 months.
We have any number of devices that are intended for various purposes in different subsets of disease. For calcium, for example, we have a Diamondback atherectomy. For softer plaque, we have a laser. We have devices to remove eccentric plaque from arteries like the Silverhawk and Turbohawk. We have devices to go through total blockages like the Wildcat and the Kitty Cat and the Front Runner and the Crosser. And we just have any number, there are probably a dozen or so of these different specialized devices for different indications as we run across particular problems in selected patients.
So the first option is just balloon. The second option is atherectomy plus balloon. The third option, which can be used in either by itself with balloon or in combination with atherectomy with balloon, is stent.
Where we have, bending of the hip joint, we try not to put stents unless we have to. If you have a lesion there that you can shave it with the atherectomy device, some kind, I probably will look into that. Some vessels are calcified, very difficult to open with balloon. Some of them you can do orbital atherectomy device, just shaving gently the surface of the artery, and therefore able to dilate it with balloon or stent.
For the heart, where the heart is moving but the vessels are relatively stationary, it's wonderful to place stents. Unfortunately, when you use your legs and you walk, there's so many forces involved in the legs. There's both twisting, pulling, and pushing. So there's 3 different types of forces. Newer stents are being developed that are more flexible, and so we're seeing better results with those stents.
The technology in the interventional arena is so much developed that we now have excellent stents and balloons to treat people with severe peripheral vascular disease.
Since the vascular specialists have teamed up 15 years ago or so with other specialists and been more aggressive in treating peripheral vascular disease, we've been able to cut the amputation rate in this country in half.
The cost for the society is enormous. For instance, cost of a patient with after amputation in nursing home up to $100,000 a year.
I guess the question is how much is your foot or your leg worth? And there is certain times when amputations are needed. However, our goal is to have everyone keep their feet as long as they can.
That's right. Less than half people after amputations able to regain ability to walk again.
So in addition to the emotional strain of having, losing part of your limb, there is an increased economic burden on the health system by having an amputation. It's actually cheaper to do multiple peripheral interventions than it is to have someone have their leg amputated and then the health burden that become on the system.
I think one of the most unique parts about the Arkansas Heart Hospital and the Peripheral Vascular Institute is the fact that we not only do we identify or seek out the disease process, but the other component that is oftentimes left out is the management. The patients seen by advanced practice nurses who are specially trained in the management of peripheral vascular disease. We have a team of licensed practical nurses and medical assistants, as well as an RVT or registered vascular technician on staff. Where we come in the peripheral vascular disease management program is that these patients are followed on a regular basis to learn how to take care of their disease process, everything from exercise to risk factor reductions like smoking cessation, cholesterol management, following up with the ABIs to watch for trends or recurrence of symptoms, because unfortunately some of these patients do have reoccurrence. It is a chronic progressive disease, and to just help the patient be able to function within the limitations of their disease process.
So we're very excited at the Heart Hospital about 3 trials we're involved in right now: the EXCITE trial, the CONNECT trial, which is now completed, and the EASE study. The EXCITE and the EASE study both are looking at atherectomy of plaque and scar tissue compared to balloon angioplasty. The EASE study is looking primarily at the efficacy and safety of a new investigational device for atherectomy.
We did initially 20 cases with Ocelot, and then we're bringing Ocelot back in a month or so to begin another 20 cases.
I've been involved in CONNECT 2 as the primary investigator, and then as a sub-investigator with EXCITE. So both are studies that we have used for treating peripheral vascular disease. One of the main hurdles that we see in treating in opening blockages is not only how to keep the artery open or how to treat the artery, but first to cross the blockage. Chronic total occlusions, before you can treat that, you have to actually cross that. And so what we have several devices that again help crossing those blockages.
The Ocelot is essentially is a catheter with a camera mounted on top of it.
This is a new device for opening totally occluded vessels. They allow us to image the artery with what we call OCT. OCT is a way of directly looking at the vessel. It's different than ultrasound. It uses a different technology.
As a 2D image, you can just see from the outside. You can try to guess that you're going the right way. With having the camera on the drill, you can actually see that you're in the artery.
With a look at that 3D image, we can tell if it's hard plaque, soft plaque, where the little cannulations are, where tributary arteries are to avoid, and keep us right in the mainstream of the lumen of the vessel.
It greatly enhances our ability to cross blocked vessels and effectively treat them.
Using these trials as a backbone of how we treat patients allows us to broaden our horizons and cross new frontiers. Hopefully, we can get a better handle on this disease as it continues to be a major cause of morbidity and mortality in America.
Since the new devices and new options are available on the horizons, and we're part of the trials and a part of the research, the active research ongoing in this area, and we expect that over the next several years we'll have even more options available to treat those problems.
We have been fortunate enough to be exposed to the latest technologies and frequently in an investigative fashion, and most commonly we are the first in this region to be able to apply these new technologies for the treatment of peripheral disease.
Okay, we're here in our 4 peripheral labs. As you can see, Dr. Rollison and Dr. Lendl. We perform on the order of 1,500 to 2,000 peripheral cases per year at this hospital, roughly 30 to 40 per week.
For angiography here we use GE equipment. The patient stays stationary on the table and the table itself moves to get our images, and also the camera, or the eye as we call it, can move around the patient. When we use contrast from an assist injection device, which will inject the contrast as we take pictures with the equipment, the images will directly come up on our monitors here, as well as all of our hemodynamics. Same time, in the control room, where we have a nurse basically capturing all of the information, putting everything into the computer about what the procedure entailed, any equipment that we use, as well as working in conjunction with the physician and the x-ray tech in the room to get any equipment that's needed, pull up any old information, which could include old stents, what types of tests were run previously. All that information can be taken from out here and relayed to the team that's working inside the lab.
Yeah. I mean, they say position it exactly where I need it, right? Okay. So we'll have to really bunch these cells up.
So the suites here at the Arkansas Hospital, they have both the facility to be cardiac and peripheral suites. One of the suites here actually has a special equipment that we use for looking at specifically the periphery, which is called digital subtraction. It allows us to actually see the arteries better, and by removing the bone overlay. So it's like taking the X-ray and then removing all the bone and just leaving the artery. So it's a very helpful equipment to have. We can use that information to create an overlay structure so that you can treat certain places in the leg without having to give contrast. And so that also saves the patient from giving them contrast.
Excellent. Technology at the heart is pretty phenomenal. Just about every device that you can think of, we have or have used it. Different devices, wires, balloons, devices to open vessels that are totally closed. The hospital is really quite far advanced in peripheral vascular disease and treatment.
Our intention as the clinic and all of us as a team, I think, is to increase the awareness in our patients, do the early screening, and if you find someone who has severe disease that we can intervene upon and change the disease progress, I think we will make a huge impact in their life.
Many times patients will have had leg pain and they think it's arthritis, they think it's too many birthdays. There are many other things that overlap, and so I think that's one of the most important things as providers, as a takeaway message when we talk about peripheral diseases. Consider evaluating those patients, because pain is not normal, and just because you have a few birthdays and you have a little arthritis doesn't mean you shouldn't be able to walk to your mailbox and back, without having severe limb pain. So it is functionally debilitating, and we need to always ask that question, I think, could it be peripheral vascular disease?
Our goal is to keep them from having to have a prosthesis. Our goal is to have these people functional before they have to succumb to an amputation or debilitating peripheral disease. Too often, we end up getting involved when it's too late. The process goes on for 20 years below the surface, and only very late in the process does it manifest clinically. We're hoping to catch these folks upstream so we can treat them more effectively.
It's important here at the Heart Hospital, and it's shared among my colleagues, is that we are very aggressive with treating peripheral vascular disease because we understand the limitations, the strain that it can cause. We have a lot of patients that are very grateful and they express this because they're able to do things that they couldn't do. They can actually enjoy life. They can actually walk and run and play with their grandkids. What on our side, what we see is that we are treating diseases that can affect lifestyle, but it can also cause catastrophic things to the patient, such as losing limbs. And losing limbs has been shown to increase mortality. So anything that we can do to make our patients live longer and healthier, I think those are the vested interests we have at the Heart Hospital.